Good evening, everybody. I'm actually presenting a case on recurrent disseminated abdominal hydatid in an immunocompromised patient. This is actually about a 36-year-old man with a history of gradually progressive abdominal distension for around 1 month. There was no associated abdominal pain. There was no history of jaundice, no history of loss of weight or loss of appetite. There was no history of vomiting or diarrhea. No other significant history was there. He was diagnosed with retroviral infection and treated with tenofovir lamivudine efavirenz for the last 4 years, and the CD4 count presently is 345. There was a similar history of abdominal distension which was treated for more than 6 months, and there was complete resolution of symptoms after that. The patient was actually treated with albendazole 400 mg BAD along with praziquantel 600 mg TID. That was a cyclical therapy with a drug-free period for around 14 days for about 6 months. Patient actually lost follow-up for around 2.5 years. During that time, there was complete resolution of the abdominal pain and abdominal distension. This is the CT which was taken 3 years back. This is showing multiple cysts in the liver. The first cyst is actually this is a large cyst with multiple loculations and multiple septations. This is actually showing a splenic calcification with cyst in the spleen with multiple cysts in the abdomen, peritoneum and mesentery. This is the CT report. The liver is actually enlarged in size with multiple loculated cysts. The largest cyst was around 16 centimeters. Multiple ductal cysts were there, and there were diffuse peritoneal and omental lesions were there. And in addition to that, there was an inguinal cyst. This is a full report. There was disseminated abdominal hydatosis, and there were multiple lesions in spleen, peritoneum and omentum encasing the bowel loops. This was a CT chest taken at that time. There was a cyst in the upper lobe of lung, and presently on examination wise, the patient was having a Marfan habitus and there was mild pallor. There was an inguinal swelling in the right side. It was around 2 centimeters. And this is the inguinal swelling. There was generalized abdominal distension. There was firm hepatomegaly. The surface was actually irregular. There were irregular border and nodular surface, and the hydatid thread was present. Multiple abdominal swellings were there. There was no free fluid. Splenomegaly was also there. And coming to the investigations, there was anemia. Peripheral smear was showing microcytic hypochromic anemia. Stool routine, stool culture was negative, and ELISA for echinococcal antigen was negative. And X-ray of the pelvic bone was actually showing multiple lytic lesions with perisclerotic opacities were there. This is the X-ray abdomen. There is a large calcification in the left hypochondrium. This was also previously there in the last CT. The chest X-ray was normal except for poor exposure and slightly elevated right dome of diaphragm, and this is a CT which is taken. There is no evidence of any cyst over here, but some degree of consolidation is over there on the left side. This is the CT abdomen which is taken now. There were actually multiple loculated cysts. This is the largest cyst that was in the right lobe of liver. There were multiple small cysts. These are all active cysts. This belongs to CE1 and all. And this CT cut is showing splenic cyst with calcifications, and there are multiple intra-abdominal peritoneal and mesenteric cysts. This is showing a large diffuse CE2, CE1 cyst in the pelvic area, and this is a CT showing pelvic bone cyst. There were also cysts in the lumbar vertebra. This is CT abdomen report. Disseminated abdominal hydatid disease, multiple hepatic hydatid cysts type 2A and type 2B. There was peritoneal hydatid cyst also. Subcutaneous hydatid cyst was there in the right inguinal region. Multiple splenic hydatid calcifications were there. Multiple hydatid pelvic bone and lumbar vertebra. The patient was treated with albendazole 400 mg BD along with praziquantel 600 mg TDS with a drug-free period of 14 days in between the cycles. Comes in between the humans are actually accidental hosts, that is actually dead end, and the intermediate hosts are actually sheep, goats and swine. Whenever there is an ingestion of the eggs, that will lead on to whenever the eggs are actually ingested and the eggs actually sprout and oncospheres hatches that penetrates the intestinal wall, and that in turn leads to the hydatid cyst, and from the hydatid cyst the proctoscolex come, and that will lead on to formation of eggs, and adult worms are actually formed. The definite host is dogs, and the intermediate host is actually human beings and sheep, etc. And the primary cyst in liver is actually composed of 3 layers. The outermost cyst is the adventitia or the pericyst, and the intermediate layer is called the lamellated layer. This is actually whitish in color, and beneath this the inner layer is called the germinal layer. This is actually responsible for the fertility of the hydatid cyst, and the hydatid cysts are actually usually slow growing. The rate is around 1 to 5 centimeters per year. This is the picture showing that. This is the pericyst, exocyst and endocyst. Ultrasonography, the sensitivity is around 90 to 95%. There will be usually anechoic or smooth or roundish cyst. The characteristic thing about the hydatid cyst is hydatid sands will be there. These hydatid sands are predominantly composed of hooklets and scolex. The characteristic features suggestive of inactive lesions include collapsing of flattened elliptical cyst and detachment of the germinal layer from the cyst wall, that is called as water lily sign. And whenever there is a calcification called as eggshell calcification, that usually occurs in CE5. There are 2 types of classification, Gerby classification and WHO classification. There are type 1 to type 5, and CE1 is actually univesicular anechoic cystic lesion with a double line sign. CE2 is actually multiple multiseptated rosette or honeycomb cyst, out of which type 1 and type 2 are active cysts, and the type 3 is actually in the transition phase, and type 4 and type 5 is inactive phase. Type 5 means there will be calcification, type 4 means there will be heterogeneous content along with some cystic lesion. There will be no daughter vesicles, whereas in case of type 3 there will be type 3A and type 3B. Type 3A means there will be water lily sign. That means whenever the intracystic pressure comes down, that may lead on to detached membrane. And type 3B is actually cysts with daughter vesicles, but there will be solid matrix along with that. CT and MRI are actually somewhat similar. Both can actually be used. The overall sensitivity is around 95 to 100%. This is very useful in detecting the recurrence and monitoring lesions during therapy, and also for the assessment of complications such as infection and intrabiliary rupture. The treatment is actually surgery, predominantly surgery. Surgery is used for complicated cysts, as in case of ruptured cysts or cysts with biliary fistula or cysts with compression of vital structures. Whenever, and in case of WHO stage 2 and stage 3B, the treatment of choice is surgery, whereas in case of CE1 and CE3A, the treatment of choice is pair. Whenever the cyst diameter is more than 10 centimeters, surgery is the treatment of choice, and extrahepatic cysts such as lung cysts, bone cysts, brain or kidney cysts, the treatment of choice is surgery itself. This is a treatment summary. Whenever there is CE4 or CE5, there is no need of treatment, early observation is needed. These are the multiple case reports of disseminated intra-abdominal hydatid cyst. This is actually published in Hindavi, that was showing a disseminated abdominal hydatid cyst. According to this journal, they have actually tried a similar protocol. That means cyclical therapy of albendazole with praziquantel was given. Most of the studies are saying like praziquantel can be added, but not much of benefit is there. This was published in BMJ. This is also a primary disseminated extrahepatic abdominal hydatid cyst. This is another case report in which they have tried actually 400 mg of albendazole with praziquantel 600 mg TDS. The importance of this study is actually the dissemination of the hydatid cyst without rupture is very rare, and since it is an immunocompromised patient, the chance of dissemination is also likely. Then the patient was also having a right-sided inguinal cyst, so the subcutaneous cyst is not that common. Subcutaneous cyst can actually occur as a part of dissemination from the abdominal region that can actually migrate through the inguinal canal. And the bone cysts were there, so it's a combination of bone cyst, multiple intra-abdominal hydatid along with inguinal cyst in an immunocompromised patient. Thank you.